Well, good morning. My name is Amy Dean. I'm the nurse clinician for the Medical Respiratory ICU at Virginia Commonwealth University Health System.
And I'm Kristin Miller. I'm the Associate Medical Director at VCU Health in Maricu.
So we are just delighted today to be able to present our project. Our project is titled Collaboration and Coordination in the Maricu. It's an interprofessional approach to the implementation of a daily review of sedation strategy, liberation potential, and a mobility plan. Now, through this presentation, we need to take a step back and look at some of the background of who we are. So we're going to discuss who the Maricu is, the program in which we were involved with. We're going to look at some of the science of our project. We're going to review some data. And then after we review the data, we'll look at some of the cost of our cost savings plus the cost of our program. And then I think that will wrap up our business case for a high value of continuing professional development. So to begin, the Medical Respiratory ICU, which we lovingly call the Maricu, is a 28-bed ICU. We specialize in the care of the critically ill. Oftentimes, our patients are on mechanical ventilation. They also require continuous renal replacement therapy, and a lot of times they have continuous infusions of vasoactive medications as well as sedatives. And so our team actually has two services. It's a red team and a blue team. They are very similar in design, and we admit patients to those services just on a rotating basis. We have a very established interprofessional team which consists of nursing, medicine physicians, advanced practice providers, physical therapy, occupational therapy, pharmacy, and respiratory therapy. So the program in which Dr. Miller and I were asked to join is the VCU Langston Quality Scholars Program. This program is a collaborative effort between our VCU School of Medicine, our VCU School of Nursing, and our VCU Health System. So this program is an experiential learning program designed to deliver the continuing professional development focused on science of improvement and enhance our leadership skills. What's beautiful about this program is they taught it in a dyad form, and so each of the groups had a dyad. The first cohort had nurse and physician dyads, and the next cohorts, I think they're opening that up to different professions. So our dyad went to both didactic lectures and had online modules, and all of those lectures and modules were geared towards the science of improvement and leadership. Our program lasted about 8 months, and we were paired with a science of improvement coach to help us implement our project.
Thanks, Amy. I just want to give the group a little bit of background about the science behind our project. Amy and I are both very passionate about the ABCDEF bundles, and these bundles represent quality in ICU and our standard of care. Our references come from ICULiberation.org, SCCM, also endorsed by the American Association of Critical Care Nurses. Basically, what the bundles are best practice medicine in the ICU. Briefly, A stands for assess, prevent, and manage pain. B, both spontaneous awakening trial and spontaneous breathing trial. That's a period during the day where you reduce the sedation in the patient in the ICU so that they'll be awake enough to interact with you and potentially breathe on their own to see if we can liberate them from the breathing machine. C is going to reflect the choice of analgesia or sedation, i.e. the medications that you choose to sedate your patient. D, assessing, prevented, and managing delirium. E is early mobility and exercise, and last F is for family engagement and empowerment. For our project, Amy and I chose, as we met with our group, to focus on 3 of these bundles, B, C, and E. B, again, is that spontaneous awakening trial and spontaneous breathing trial, setting a time each day to reduce the sedation level for your patient, assessing that patient's wakefulness, and then putting them on minimal support on the breathing machine to see if we can actually get that endotracheal tube out or get them liberated from the breathing machine. Studies have shown that synergistic use of both the spontaneous awakening trial and the spontaneous breathing trial decreases duration on the ventilator, decreases hospital lengths of stay, and decreases delirium. Moving on to C, that's the choice of analgesia and sedation, the medications that we order and the nurses titrate for the patient's sedation. ICU sedation is important. Patients experience pain. It can help them be synchronous with the breathing machine, and sedation can decrease traumatic memories. However, there's only a small subset of patients that really need deep sedation in the ICU, and deep sedation has been found to reduce 6-month survival, increase hospital mortality, ICU and hospital length of stay, time on the breathing machine or the ventilator, and physiologic stress to the patient. So when we look at C, that's based on evidence-based guidelines from the pain, agitation, and delirium that was released and updated by the SCCM in 2013. Along those lines, we use the Richmond Agitation and Sedation Scale. We're proud to say that was developed at VCU Health, and it's one of the sedation tools that can be used by nursing to help titrate to a goal RASS for that patient. And RASS is just a score that's given to the patient. It varies from 0 to +4 in a very combative patient to -5 in a comatose patient. Ideally, we'd like our patients to be in that 0 to -2 where they can be alert, and just lightly sedated. And lastly, we focused on early mobility and exercise, the E of the bundle. We know that ICU-acquired weakness is a problem. It leads to decreased functional mobility. Patients who are weak, they are on the ventilator longer, and they have an increased mortality. We have a recently developed ICU mobility tool that we use that is a safety screen in place, and then different levels, whereas the level 1 being bed rest, ultimately up to the goal of level 5, where that patient is independent. This is an example of a patient with permission in our ICU who actually is intubated on a ventilator. This is the bedside nurse. This is the patient's monitor. This is the patient's husband behind her who actually has a chair in case she needs a break. She was able to walk down the hall.
So why did we choose to focus on this? So the science is good behind this. This is what's best for the patients, and we are passionate about patient care. So the problem is that we were having a hard time getting traction for this project on the implementation. And so through the coaching of our quality of science expert, she asked us to first build our team. And she was like, you need to get a lot of people engaged. So we built our team based on representation from our unit. So we had attendings and fellows, nurse practitioners, RNs, both clinical coordinators and bedside. We asked our physical therapist, occupational therapist, respiratory therapist, and our pharmacist to join us to really get to the crux of the problem. And so when we were looking at the problem, it wasn't that the science wasn't good, it was that we were having a hard time communicating and coordinating the care of this best practice bundle. So we developed our goal statement, and by October 16, we wanted to achieve daily interprofessional communication and coordination of the care relevant to the patient's sedation level, liberation potential, and the mobility plan for all MRICU Blue Team patients. Now, as we move forward, it's important to note that our intervention was on the Blue Team, and our non-intervention team is the Red Team. And so through some of the science improvement tools that we learned, one of which was the PDSA cycles, the Plan, Do, Study, Act, and those cycles show small tests of change. And so with our group, we developed our solution after about 5 cycles of this PDSA. So our solution to the problem was to have daily interprofessional huddles at 8 a.m. in the morning and have a very scripted conversation that lasted 2 minutes or less per patient. And by the end of that 2 minutes, we were able to have a plan for sedation, liberation potential, and our mobility. So here's a picture of our scripted tool that we use. The top is information that we gathered beforehand, and then the bottom shows the plan of care for the day concerning those 3 things that we focused on. So we bundled a lot. And so our data here is from July 12th to October 31st of 2016. And we bundled on 53 patients, and we had 269 huddles over that time. So we're about to show you the drill down data that includes 14 patients and 50 huddles. Now, some of our data also includes the 269 huddles.
So this is a summary of the outcomes that we noticed in our patients that were in the Blue Team that had the bundle huddle. We had an increased time at that sedation goal, the RASS goal. We had decreased use of benzodiazepines, which goes in line with national guidelines. We had increased compliance with spontaneous awakening trials and spontaneous breathing trials, and 99% of intervention patients actually had a mobility plan. So to break that down a little bit, one was the increased time at RASS goal. You'll see here is the pre-intervention data, and here's post-intervention data. Just want to note that post-intervention, many more of the patients were at the RASS goal in 24 hours, 100% of the time. In terms of medication and that C, the choice of sedation, we really wanted to go down on our benzodiazepine use. You can see our pre-data, 20% of our patients were in a benzodiazepine Versed infusion. And then in our post-intervention, that went down to 5%. We had more of our short-acting agents such as propofol and Precedex. We had increased compliance with our SAT, our spontaneous awakening trial. Pre-data showed 45% of patients had that. Post, we went up to 92%. Similar with spontaneous breathing trial. Pre-data, we had 41% compliance, and then 89% post-intervention. And then in terms of mobility plan, 16% of our patients had a mobility plan pre-intervention. That went up to 99% post-intervention. In terms of looking at length of stay data, we found a decreased inpatient length of hospital stay for MRICU Blue Team patients in the intervention. That went from 11.01 days to 7.75. And the Red Team stayed about the same, 9.95 to 9.22. And we even saw a decrease even when it was looked at by DRG. In terms of average ICU days for MRICU admissions by team, our intervention team went down from 4.96 to 3.14 in the blue team, whereas the average ICU days actually went up in the non-intervention team or the red team. When we look at this in terms of trying to estimate a cost savings, we looked at the length of stay difference. It was 1.14 days. We used data from Desta et al. In 2005, and they estimated the average cost of an ICU day at $31.84. And when we look at that, an annual expected length of stay difference and potential yearly savings, if this was implemented year-round, is $2.26 million. When we looked at specific cost data to charges, we found in our non-intervention team, the MRICU accommodation charges, i.e. the cost of the room, actually went up in our non-intervention team, similar to respiratory therapy charges, which is the cost of the ventilator, the oxygen supplies. But you look in our intervention team or the blue team, that the average charges actually went down for both MRICU accommodation charges as well as respiratory therapy charges.
So we looked at our cost savings. What did our program cost us? So the Langston Quality Scholars Program, including the faculty, the online access to the IHI modules, the education supplies, et cetera, the total program for our dyad, the total cost for our program was about $97,000. Now, there were 8 teams with 16 participants, so if you were to break that down for just Dr. Miller and I, it would be about $12,000 for our program. To look at the cost of each huddle, if we had attendance at each of those huddles, each huddle cost us about $120. So when we're trying to determine the value, it's very multifactorial. We got to look at the outcome and the qualities, and then take that over the cost. So our outcomes, we had great length of stay data. Our patient-centered outcomes were awesome. We had decreased healthcare costs not only for the patients but for our institution. Quality-wise, our staff satisfaction increased. We had interprofessional collaboration that we've never had before. In that way, in the MRICU, we had improved communication between the different professions. And an added bonus is that through that program, Dr. Miller and I now have science of improvement skills and knowledge that we can take to other projects throughout the institution. So we weigh that against the cost program and the cost of the huddle, and I do think that in conclusion, we do make a great case, a business case for high-value continuing professional development. Programs like the Langston Center provided us with the tools and the knowledge needed to have a successful QI project. And when programs similar to the Langston Quality Scholars are implemented, I do believe that strategies such as those will be able to decrease your health care cost and have a successful return on investment. Thank you.